Primary nursing plays a pivotal role in partnering with parents. We're so pleased to have Liz Drake join us again as our faculty presenter. Liz has been a practicing neonatal nurse for 32 years. She has practiced in different roles throughout her career, but the time spent at the bedside with the patient, family, and staff is most meaningful to her. Developmental care, family-centered care, and quality improvement are her passions. She is currently the CNS in the NICU at Chalk Children's of Orange County, the Mission Viejo campus. She is a published author, participates in ongoing clinical research, and is a nationally recognized presenter and consultant. Liz, welcome, and thank you so much for being with us this morning.
Thank you so much, Kathy. I'm so excited to spend the next hour with all of you. As Kathy shared, I'm coming to you from Southern California, and no, this is not Southern California. It actually is 80-degree weather right now, which is even unusual for us. But as many of you have had fall colors, and some of you even maybe getting some snow, we too in Southern California get autumn, and this is my front yard. And I'm sure many of you are laughing at me, but you know, humor me. We do get a little bit of an autumn here in Southern California. So I wanted to talk to you a little bit during this webinar. I love webinars, but I have to admit it's kind of funny sitting in a rocking to yourself. And it wouldn't be the first time I found myself doing that, but it's a great way to get education in such a personal way. But I chose today's topic because we're all faced with the challenges of continuity of care. We are frustrated when it doesn't occur, and we have such fulfilling days when it does. We're in a field where there are physicians, consultants, other disciplines. We have day shift, we have night shift, and we all need to get a job done, and we all have different views and different ways of bringing those views to the family. But in that process, sometimes the continuity of care for the family is disturbed. One NNP, her name is Mary McAllister, wrote an article, and it was called The Continuity Conundrum. So I thought I would dive into this topic with an emphasis on the role of primary nurse and actually how families utilize this pivotal role to help them walk through the NICU experience. Because sometimes, as we all know, it's a very trying time in their life. What we're first going to do is spend some time looking at the background literature to help lay the foundation for what successful continuity of care and primary nursing might look like. So what I'm going to do is we're going to review the literature, and as we review each piece of literature, I'm going to ask us to ask ourselves personally, what could be my take home in this, in my culture, in my unit, and how might I apply this and integrate this to put a primary nurse program into place, but ultimately really providing the continuity of care, because that is the foundation of what we're going to talk about today. So I'm going to push us a little bit and have us take a different perspective and look at the literature from the parent's point of view, and that is really actually where most of the evidence comes from in that qualitative type of research. So the first thing I want to do is just kind of review some of the objectives that we're going to hopefully gain some knowledge after we spend this hour together. We're going to talk about 3 parent perceptions of continuity of care. And then I want to talk about 2 elements for establishing a successful collaborative partnership with parents. And we're going to talk about that term a lot, collaboration and partnership. Parents have identified that there are 3 phases of this relationship. And one thing I want to rest on also, and this is on the healthcare side, is how do we work together in an interdisciplinary team? How do we practice together? Notice I didn't say multidisciplinary. Multidisciplinary sometimes tends to drive silo practice, and this is interdisciplinary. How do we work together? How do we make our observations, our assessments, our plans of many of our disciplines, and how can we communicate it with one voice to the families? And then finally, I want to rest on us as professionals, whether no matter what discipline we work in, how do we maintain those boundaries? How do we have personal and professional growth? And I believe in my heart that if we have this spirit of inquiry, if we are not afraid to ask ourselves the tough questions and not get comfortable in our practice and be willing to grow, whether you're practicing for 2 years or 22 years, that's truly when we grow, when we're not afraid to ask ourselves the tough questions. And then how do we support and encourage each other and champion this interdisciplinary practice? So here we go. So let's just get some definitions out in the open here. So continuity, the term from Merriam-Webster, says it's the quality of something that does not stop or change as time passes. It's a continuous quality. It's something that's the same or similar in 2 or more things, and there's a connection between the 2 of them, okay? Primary nursing as a model of care, a definition of this in healthcare literature, again, healthcare literature, is when a single or group of nurses are responsible for coordinating and continued individualized care for the patient and family, and it emphasizes continuity of care. And according to the Institute of Medicine, care should not vary illogically from provider to provider or from place to place. Now, that's a tough one because many of us do have different campuses, and even my institution has 2 different campuses, and it takes a lot of collaboration and communication and continuity amongst ourselves to provide that continuity of care when our families might need to go from campus to campus. But even the Institute of Medicine is talking about care should not vary illogically, and we know that happens every day as we have different doctors every day. And can you imagine, if it's frustrating for us, what it must look like to the family when we have different nurses, different physicians, different therapists? And I can't even imagine, again, how illogical it must seem to them sometimes. From the definition of continuity of care across disciplines, I thought this was kind of interesting to look how the different disciplines actually view it. In primary health care, which is the way our country is founded on, it's where there's a relationship between a single practitioner and the patient extending beyond episodes of illness or disease. So that means from when we go to the doctor, it's from one cold, and then we have health again, and then we go see him for another period of time. But it's this relationship that's built with our primary care physician. In mental health, they emphasize coordination of services and stability over time, but it's established with a team rather than a single provider. In nursing, we emphasize it as a consistent approach to care. We look at it as the way we provide information and the way we coordinate our care over time. And we actually look at it also as how we communicate between nurses, between each other, between shifts, between days on what is going on with our families. So you do see one theme here, that it is care of an individual and patient care delivered over time. And what you'll notice is both elements must be present for continuity to exist, but their presence alone doesn't constitute continuity. And we know that. We can think we say the same thing, we can think we provide the same care, but unless the family feels that continuity and it's practiced across the board with every single discipline, the family's not going to feel that. So let's talk a little bit about the different concepts of continuity of care and primary nursing specifically. So continuity of nursing care, actually, there's evidence that says it promotes nursing empowerment. We feel empowered. We feel like we have some, for lack of a better word, control over what happens during our day and what we want to provide to families. Primary nursing makes work meaningful. It increases our satisfaction when we know what we can count on and what we know what our goals are when we partner with a family and we actually see improved outcomes. Primary nurses help parents participate in a high level of contact in their infant's care, or it should, and that's what we're going to talk about a little later. It's defined as the degree that fewer nurses are assigned to care. And I think that's probably, if we were to go across the country and ask everybody what primary nursing was about, that would probably be our main definition, where fewer nurses are assigned to a family. Families actually felt that the quality of care and the moment-to-moment, what they called it surveillance, was better with primary care. They felt like their baby had physical safety when there was a primary nurse or a primary nurse team. Literature did show generally that mothers developed more significant relationships with their primary nurse. Nurses who consistently cared for infants and their family provided great information that helped the family understand over time. They didn't feel like They had to get to know their nurse and use all their energy with there. They knew that person. They knew how that nurse communicated, and family understood better over time. It's a team of people that care for an infant and family during the entire hospital stay. It's in a consistent way, a consistent approach of communication and routines. And the term continuity and consistency are interchangeable. One of the biggest hospitals that do discharge phone calls or discharge surveys after they go home, families will come back and across the board say that continuity and consistency of information and staff were their biggest satisfiers or dissatisfiers if it did not happen. And then finally, continuity of care is where structured support systems and healthcare providers' perceptions of right now we view it as what parents might need rather than based on parent input. So that's what I wanted to do today. I love this little picture where we think we're little kittens, and what's coming back and what the parents are seeing is this roaring lion. So I think we have to ask, we might be basing our programs on what we think parents need, but we don't really know what parents need until we ask them. So I want us to kind of look at ourselves a little bit more today as professionals. So our first piece of evidence, and again, most of the literature is qualitative in nature. And it was parents' perceptions of continuity. And they broke it up into, there was informational continuity, there's management or interdisciplinary continuity, and then relational continuity. An informational aspect of continuity was the importance of consistent information and this common thread between providers, not just the nurse, but providers over time and about events. And another thing that I thought was very valuable in this was the family wanted to know that we managed their information about their family and their infant. For example, if one of us received some information about what a family was going through or when a family was going to come or anything in a particular shift, and then the next shift, if the family came back and we started talking to them and we didn't quite get the story right, that makes them feel like we're not communicating to each other. And it's not just nursing, it's physician to nurse, it's therapist to nurse, whether you're a respiratory therapist or occupational therapist, lactation, whatever your discipline is they really wanted us to get the information straight about their family because it's very personal. The second type of perception was this management and interdisciplinary continuity of care. I want to focus just on the one of where they wanted us to eliminate the potential for providers to work across cross-purposes without understanding awareness of other services. This is where we really need to push ourselves to understand and respect not only the expertise of other disciplines and how that brings continuity, but awareness of what those other disciplines have and what they bring to the table for this family. Because there are so many aspects of the baby's care that is important. As a NICU nurse, do I know about lactation? I do, but my lactation therapists are the experts, and they are going to provide the best continuity of information that is going to be most helpful to the staff, to this family. The physicians have an aspect and an expertise that I do not have, so I need to not disagree, but actually believe in their purpose from their perspective and help the family understand. That's the point of the value of us being at that bedside for 12 hours, which is so pivotal. We are the hub of that wheel and help that family understand the important aspects and expertise that all of our team members bring. And then finally, relational. I love this quote by Robinson. He says, relationships are not central to care, they are care. And we know that when we have a relationship with anybody in our life, when we communicate, there's so much more honesty and acceptance, and we relax and we're comforted. And if you think of our families during their experience, the lack of comfort they must feel, they are totally out of their surroundings. So when we build those relationships, it's pivotal for them. It's a relationship that endures over time, and it's that sustained contact that gives them that trust and that safety. Another piece of evidence, literature, is one called A Parent's Perspective, Mothers in the NICU Outside to Partner. And it looked at 4 different aspects. It looked at the focus, ownership, caregiving, and their voice. And at first they saw a focus. It moved them from the NICU to their baby. So when they first came in, you know, focused on the alarms and the NICU and how they should behave and where they should sit and when they can touch. And then finally it was, this is my baby. So they saw that transition when we had a partnership over time with them. They saw, they looked at this concept of ownership. Moms felt like it was the nurse's baby, and then they moved it to their own baby. So it moved from their baby to my baby. Caregiving was originally passive, and then it moved to active. And then in the beginning, they felt their voice was silent, and they moved to advocacy. And these were two statements out of this evidence. And it said, sometimes I feel like I'm just a spectator, just watching, just going in to watch is basically what I do. And I thought, oh my goodness. And that's that silence to advocacy and that passive to active. And again, that their baby, meaning the nurse's baby, to it finally being her baby. And then another mom said, if I know that Billy has a nurse who has never had him before or had him a long time ago, I won't leave until her shift is over. And I've got this little girl here going, so what? And this is my take-home piece of information. So what I want us to ask in this, when we look at this piece of evidence is, what is the take-home? And I want us to say do I, when I'm caring for a family, no matter what role you are in, do I speak as if it's my baby or do I speak as if it's her baby? And depending on your answer, yay if we say it's her baby, and if we tend to use the terminology, you know, my baby, and we do, we're protective, we're NICU nurses, that's why we went into this field, and we're lifers. We love what we do, but how can we empower ourselves to say this is her baby and I'm going to help her walk through and bond with her infant? This actually was one of my favorite pieces of literature. And I actually have 4 vignettes. I'll interject this here. I have 4 interview vignettes that I have placed in this. I'm going to play them. They might be a little bit quiet, a little bit difficult to hear, but I will summarize them. And I just think that they're powerful because we can actually hear from families what their perceptions are. So this article talked about fathers' experiences of search for control. And across the board, the themes were a sense of lack of control, information, communication, and their role. As far as lack of control, it was a universal response. Even though fathers might have had different views, the universal response was it was consistent. Issue of trust and lack of control. As far as trust, dads either said, you are giving proper care and are in control, and I don't have to worry. They trusted all of us. And they actually would kind of disappear. And I thought that was interesting because so many times we could all admit, we'll just say, Dad never comes in, he must not be engaged. And actually, he might be saying, you guys are wonderful, you're in control, I don't have to worry. I can go do what I need to do as a father and leader of my household. The second one was a lack of control, where they felt it was out of my control and they had to remove themselves from the situation. So see, when a father is not at the bedside, we have this perception of he's not engaged, but he actually might feel so out of control, he does not know what to do, and being in the situation makes it worse for him. Or, I trust you, I don't have to worry. The second one was information, and that provides some aspect of control. Going through the numbers was a way of obtaining direct information. And if we were all in a conference room, and if I said, okay, everybody, what is the common phrase that we say to dads when they are looking at the monitors and they are asking about the numbers, we will say collectively, and we can all say it in our homes here, Dad, don't look at the numbers, don't look at the monitor, just be a dad. And after reading this article, I told myself and realized, oh my gosh, he is being a dad. That is something that helps him gain control. This information is critical to his belief that he can make appropriate decisions regarding his child's care, even if he doesn't understand the big picture, okay? And finally, the third aspect is communication, consistency of information from an identified person communicator, whether that be the physician or the primary nurse. One dad in this article said, a good doctor is someone who knows the content. A great doctor is how he interacts with us. And then another parent said, I think more nurses need to take courses on how to communicate with parents in a respectful. They felt like sometimes we talk down to them and not to them. Okay. And then finally, I want to read this little excerpt from this one article. And it said, and it's the dad talking about his role. And he said, one father summarized his redefinition of his father role aptly by saying, I had spent 9 months thinking about what it was going to be like to be a father. And what happened was nothing like what I thought it would be like. So I sort of had to recreate the wheel in a way. The same father also stated, I couldn't feel like a father because it was about survival, this fundamental thing of breathing. I felt like a nurse. I think she needed that more than she needed me as a father. Feelings of being a father were altered significantly after one father held his daughter for the first time. He said it was the first time I finally felt like I was able to be a father rather than a healthcare practitioner. Before that, I felt like just another one of those doctors and nurses there, just making sure that she is staying alive. And when I read that, I just realized one of the things I was going to change in my practice is never tell a dad, just be a dad. If he needs to look at the numbers in the monitor to give him some semblance of control, I want to offer that to him. So the take home for me, and what I want to challenge us with is, do we regularly schedule meetings with a primary physician or primary nurse? Because that is one of the things that dads need, and they need us to ask them what they are thinking. What is the consistency of our message when we are talking to dads? We actually, we have one NICU nurse who is male, and our dads really connect to him, and I've really seen that over the years. And I think that's helpful for them. And another take home is it's okay to ask for information, and then do we let them, or do we tell them to just be a dad? So now I'm going to share one of those videos, and let's see if this works here. I'm going to actually, okay, hold on here.
Good or bad, I mean, we were deathly afraid because bed rest, and it's like, oh, I made it to 24 weeks, yay, I made it past where I got before, but who cares? Gray area. We don't want this baby born
Right.
yet.
Yeah.
People that haven't had preemies,
They don't
they have 5 kids, everything was easy, one came out of the bathtub, you went home 3 hours later, everything was fine. They take your kid home, slap a diaper, feed it, it's all zero problem. You never worry about all the things that you worry about, obviously, when you're in that.
Well, and so I do want to say when you come home, there's the, thank you for not being dead, and like being, earlier we were saying that for our baby, and that's why I'm breathing. Like, well, he breathes every single day, we still worry every single day.
Yeah, I mean, I said I didn't even know what he looked like until we left the unit, because all I knew was the monitor,
Okay, the one thing that was significant for me was his statement. I didn't even know what he looked like until we left, because all I did was look at the monitor. And if you listen to him, he was very businesslike. So anyway, I'm hoping we take a little something away from a father's experience. There is very little literature on how fathers experience the NICU, and I was really happy to find this. Okay. Next, a study about highlighting perceptions of nurses, physicians, and parents regarding primary nursing. And this was great because it was one study that had all 3 disciplines involved in this. And they looked at primary nursing and the primary nurse role as coordinator of care, that what we do has an aspect of being task-oriented, relationship-oriented, and then they talked a little bit about the initiation of the role. So as far as coordinator of care, we hold it together. We keep it together. We advocate. We identify problems of the infant, and then we consult with other professions. Again, remember that hub on the wheel. That is that pivotal role. We are there 12 hours with that family. We really are their family also. All 3 of these these disciplines, and well, I won't call the parent the discipline, but these groups of people also saw us as addressing technical issues and treatments. We provide the therapies that are ordered. We are very relationship oriented, and yet that's really probably why we went into this. We have an emotional understanding and availability to the family because we are there when they can't con their baby. We see that crying. When we look at those babies with NAS, our hearts break that we cannot console. So we are very relationship oriented. And the family see us as guarantor of good care. We are the protector. We are the nurturer when they are not there. And then finally, they talked about the initiation of the role. They saw it as either early, upon admission, delayed or absent, which is like a late onset or not at all. And then random, which would be it just happened. Nurse-based, which was the nurse had a connection with the family, had a personal interest in that baby that had a certain diagnosis. Maybe they like to take care of infants on nitric oxide or very low birth weight babies or infants with Down syndrome. Or experience-based through careful consideration. That is maybe some nurses are stellar with skin care and take care of ostomies in such a best way because they have that expertise or that love. And so I want to show you this next video that talked about primary nursing. Let's see if we can get this to work. Oh, not that way. See, a jack of all trades. As a nurse, you have to know technology. Primary nurse.
The nurses. So we didn't really understand the breakdown of charge and all that yet. And then we didn't understand primary nurses either, because it just kind of evolved to be, which I think is probably okay, but
that's the way it usually works.
Yeah.
Two in the evening and then one.
But I remember we asked Jean about it because we noticed that we were getting different nurses every day, and we were like, is there how does this work? Will we find a time where we can talk to the person ever? And we just happened to ask Jean, and of course you guys started connected, and we also did.
And she's great.
And then every time I was like, what days are you working? And then you get a day off, and I was like, I didn't approve that. So that was really good. And Heather and Tracy, I guess had signed themselves up in the evening, and that was really great. The one thing that you start to get spoiled a little bit, and it becomes harder when, like Brandon was saying, it's like we've been assigned to so many nurses, and you get somebody whose face you have, and you're like, how is that possible? How can we be 9 weeks in and we're assigned somebody who's never seen, and you're kind of like, at this point. I know the only time that it was really a challenge was right towards the very end when we were in the final stretch, and part of the challenge was, and we can talk about this too, the final stretch days was when he was trying to do the seed minimums, and we were assigned to a pig nurse at night, and so we're not there as much at night, and then it's somebody who's not even NICU, and he's trying to do these minimums, and it's like, okay, that would keep us up at night.
Okay. Come back to me here. I want to go back to this slide here. So a couple of things that hit me, she talked about, was the closeness that she had with her primary nurse, Jean, where she would ask him, what days are you working? And she'd go, wait a minute, I didn't approve that. And I love that relationship can be built with primary nurses. Then they stated that you start to get spoiled. It becomes harder when someone new has Valen. How can we see somebody new after 9 weeks in? And I thought about that, and for us, that's nothing. That's just our way of life. But I just thought, wow, that was a pretty strong perception from a family. And then finally, when she said it was really a challenge in the final stretch. And interesting how she sees now that she's past the NICU hospitalization, that they did see it as the final stretch, and it was the feeding aspect. But when a nurse from another unit had to take care of them, and that she said, that would keep us up at night. So our care, our continuity really makes a difference. So the take home from this, I want to ask ourselves is, if units are looking at primary nursing or providing this practice, it needs to be a process and kind of a standard. So do you want to have a primary nurse for each patient? You want to ask your unit this and your team this. Do you want a primary nurse for each patient, at least one per shift or at least one per family? Do you want a primary nurse within the first week? Do you want to say whoever's going to admit the baby? Do you want it to be expertise-based? Those are kinds of things that I would encourage you and us to ask as far as the role and putting a practice into place. But remember, it's going to be a process. Okay. I found this. I thought this was kind of fun. This cartoon. It says, "What? They assigned me to room 502? How come I always get the ultra-dramatic patients? Why me? Huh? Drama, drama, drama. I just match patients with nurses' skill sets. What's that supposed to mean?" I thought that was kind of cute. I hope you're laughing. Okay, some more evidence. This was a great one, evaluating nurse staffing patterns. This article talked about, they found that staffing with greater levels of consistency of caregivers tended to decrease resource utilization and minimize comorbidities. And resource utilization was things like length of stay, mechanical ventilation, oxygen, and TPN. And I look at that probably, for example, if a baby, maybe a very low birth weight was intubated, and you know this baby very, very well, and you were on for the next 2 or 3 days, our continuity of care, knowing this infant, knowing what positions this baby is better in, knowing the idiosyncrasies of the baby and the intricacies, might help us be more successful at coming off mechanical ventilation, because you know what this baby does, you know how they behave. That's how I perceive the decrease in resource utilization. Secondly, organizing the delivery of nursing care helped meet the patients and organization needs. Patients with a higher acuity had greater needs, but when you had that synergistic partnership, everybody was a little bit more relaxed. If parents knew that their primary nurse was on that day but couldn't be at the bedside the whole time, they still knew that the baby was safe. Some benefits they found were related to patient outcomes, staff and parent satisfaction. We all know that when you know what you're going to walk into, working in a NICU, sometimes you never know what the day is going to be like. But if you know what your assignment is and you know what's coming that day, it's helpful. And they also found some economic benefits because of the decrease in resource utilization, and length of stay. The challenges, though, and over time, when I first started, we had 8-hour shifts. Just moving to 12-hour shifts is the 12-hour shift, because you work less days, and then the increased number of part-time staff. Nursing is such an amazing profession to be in because we can do it inpatient, outpatient, but we have families too, and there is a work-life balance. So we are seeing an increased number of part-time staff and per diem staff. And while great for us, it's not great for continuity of care. And then a challenge would be that leaders should consider implementing measures to promote consistency of caregivers, with the hope of providing wise stewardship over economic resources and potentially improving health outcomes. It's almost part of quality improvement. Another study talked about parent-nurse interactions, and this was a pediatric nursing study, which involved PEDS, PICU, and NICU. And they found that the parent-nurse relationship was cornerstone, its foundation in pediatric care. And we know that, but I always love finding evidence that proves that. They talk about the concept of interaction versus collaboration. Interaction talked about just basically meaning communication, but collaboration was really defined as that working relationship between the two of parents and nurses. And they talked about the elements needed for the successful collaboration. And they were establishing rapport, a reciprocal interchange, reciprocal, back and forth, interchangeable, not just one-sided. It involved clear communication, and it involved looking at our attitudes. It was an attitude on our side, and the families said, especially it was the mothers, that this is what the article was more about, is moms felt that our attitudes as nurses and healthcare providers could create a climate that either supported collaboration or impeded collaboration. So we as nurses are in a position to control and regulate the amount of parents' participation. So again, the take home for this climate, for this mom to interact, is she going to do it perfectly in the beginning because she doesn't understand those cues? Probably not, but that's where our relationship with her is going to help that. So I challenge us to look at our attitudes, and I believe our attitudes are, we would not be in the neonatal field. We know that it is weeks upon months if we didn't want to have attitudes that welcome. But again, I just want to make sure that we look at ourselves and ask ourselves, how do the parents perceive our attitude? So when we looked at rapport, parents looked at this. What was our knowledge of their infant? What was the parents' knowledge of us? So I think giving them a little perspective of who we are and what our passions are is good. It's okay because they get to know a little bit about why we do this. When I introduce myself to families, I tell them, I said, I have been a NICU nurse for 32 years, and I love what I do. I can't believe that I get paid to do this. I love working with families. I love working with premature infants. They communicate and have such a unique way, and every day I want to learn new ways of how they communicate so that I can help them have a better life. So it's important to share about who you are. Building a rapport is also that ability to find a common connection. And then a show of interest in learning about their child's condition and them as a person, talking about their unique way they move or how they turn up their eyebrow. Those kinds of things parents just glean onto, and it's really important. And then building rapport with that consistency of staff or small groups of nurses, and that family that we've been watching talked about that. They had 2 day shifts and they had 2 night shifts, and that was their lifeline for that family. And then sharing across this continuum. Families felt that initially infants' care is provided by the nurse, and they saw that as a negative but necessary. They knew, I'm petrified, I'm barely surviving myself, my nurse has my baby's care covered. I'm not crazy about that, but I know it's okay, so I'm just going to settle into that. But once stabilized, caregiving responsibilities, they felt like they should be shared. And they loved this attitude. When a nurse said, what do you want me to do? It was like a partnership in that sense, that they didn't want me to feel I had to do everything, but the option was there if I wanted to do everything. So giving them the option, do you want to do everything? Are you tired today? Do you just want to sit and skin to skin your baby? Whatever that is. So it's sharing that care, that give and take, that reciprocity. As far as partnership, there's a great article also. And this was challenging. This partnership, it was called From Closeness to Detachment, and I hover on that word detachment. Families saw this partnership in 3 phases: the acute critical phase, the stabilizing phase, and the discharge phase. The first phase, the acute critical phase, parents viewed themselves as spectators of care. However, they didn't feel excluded because they were informed and encouraged to do cares. But again, they were spectators. And this family had a portion of a video I didn't show, and they called themselves sheep. And kind of, we were like their shepherd, and we told them where to go, and they just led, they followed us, and we led them. The second part of this acute critical phase is building a trusting relationship during this phase. This is when this occurs. Nurses felt confident in their professional role, and parents trusted their competence. Parents really look to us. They look and see if we're calm, they are calm. When we feel like, oh, things are going south quick, they look at our faces and they will feed off of us. So when we are confident and competent, they trust us more. Nurses' main responsibility during this phase is caring for the baby, and the parents know that their needs are secondary. Sometimes they don't really show us that, and they kind of, it seems like they're demanding, but they know based on this evidence that the baby's the main priority. And then generally collaboration is unproblematic due to we're all prioritizing the needs of the baby, which is survival at that moment. The second phase is the stabilizing phase, and this actually is the most difficult phase because it's very, very long. Parents are adapting to their life in the NICU and to this parenting role. This is where the phase where we as nurses start empowering parents. They are beginning to understand their baby's cues. They are beginning to understand the lay of the land. They have met people, and this is where the crux of the time is, and this is where we have to empower parents. We also have to entrust more responsibility by normalizing interaction with their baby. And parents during this phase need confirmation that they're doing a good job, okay? The relationship progresses over time, and gradually the parents are taking over. But you will notice this is a phase, and we've all seen it. They still need that close relationship with their nurse because that eases the burden. Because now it's getting really tiresome. It's day in and day out, and week in and week out now. And for some families, it's month in and month out. The interesting thing is at this period of time, we're going to start moving into the discharge phase where the nurse really needs to start detaching because this family is now connecting with us, and now we have to do this detachment phase. And I would say probably over time, over the 32 years, that I find that this is probably the hardest part for both family and nurse. This is another video. Let's see here. Let me do it the other way. This is called The Day in the Life.
You've got to manage us too, because we're the ones that have expectations or need to understand expectations. And I think that everyone was always really good about saying, okay, here's what you're doing now, here's what we expect, here's why that's okay or not okay, and regularly was really helpful. And we definitely moved away from being she, and there was a comment that it's not necessarily on my good list. I have a pro and a con list, but there was a comment about us coming in like we knew what we were doing at one point. Because then you get to a point where it's so automatic, like you just come in, wash up, go to, it's 5 minutes to take care of time, you go to the temperature, choose the diaper, whatever kind of feeding, whether it was do skin to skin time while he's being fed through his tube, or when he started to do the bottle, you just kind of get into a routine. And so we had our NICU routine.
Okay. Okay, let's see here. Let me go back. So my take on this video was that when the family said they impressed with our ability to communicate, and she called it parent management. She said because they were the ones who had the expectations and needed to understand, and these things were very helpful to her. When she said, when we said as nurses, here's what he's doing, and I would actually challenge all of us as disciplines, if you're the physician, the therapist, the lactation consultant, whatever your area of expertise is, to say, here's what he's doing, here's what we expect him to do, here's why it's okay or not okay, here's what we want to see. Taking us through things regularly. I love that phrase that she said. You might have heard her say, we moved away from being sheep. She said you called us pros because we understood the routine. And she did say that wasn't on her favorite list. She had a pro comment list and a con comment list as far as words we use. But she did say you come in and get settled, you do the diaper change, you take the temperature, you feed, you skin to skin, and it's your NICU routine. So I thought that was helpful for us to watch to see how they perceived it in that particular phase. And finally is the discharge phase. And I thought this was interesting. They described it they come all the time, and then all of a sudden during that last phase, all of a sudden they disappear. This helped me understand it. They're breaking away from the family. They're going to be us as a family, and they're going to be doing it on their own, and I'm sure that's very scary. This is where the parents are the primary caregivers, and actually we're supporters, and maybe let me use that word, spectators. We gradually let go. We have to increase the parents' influence and make them feel like they are the decision makers and they are collaborators. And we are now the consultants in parent-led care. I love that phrase, parent-led care. As the parent and nurse relationship can be a power dependence one, the parent and nurse interdependency should be emphasized during this phase. So it's very, very important. And the take-home question for me here is, do I cut the cord? Do I empower the family in parent-led care and then let go? And only each one of us can answer that for ourselves. Another article talked about nurses' perspective of their role, and there were 4 themes: getting to know parents and their wishes, involving families in day-to-day care, finding a happy medium, and transitioning support across the continuum. And this was a very honest article. I enjoyed it. Getting to know parents and their wishes. This is where we build relationship by conversation about the infant and general topics, kind of life, you know, what's happening. But diversity was a challenge. Nurses felt that when different cultures, different religions came into play, it was a challenge because, let's face it, we all have different ways of life, and maybe we don't understand the other's way of life, and how does that interfere with care? The next perspective was involving family in day-to-day care. We want to facilitate that parent-infant relationship through parents performing tasks. But what we also want to do is make sure that parents are present because they need to be there to learn the tasks. And that was one of the biggest frustrations when we talk about primary nursing or continuity of care is there's so many times we know that we want to start teaching and we want to complete teaching, but if the parents are not there, it's not going to happen. So how do we get them there? The next perspective was this finding a happy medium. We expected their involvement, but yet we still wanted to retain control. We wanted to kind of, they felt that we wanted to still have that control of that home my baby mentality. And then this one was interesting where it said we did admit to sending mixed messages. We want the family there, but sometimes it's easier when they're not. And that was a very, very honest perspective, and I'm glad that nurses were honest about that because the way healthcare is going and computer documentation and all the things that we have to do and the government agencies, there's so much pressure to do so much and to do it in such an excellent manner that sometimes if we were honest, it would be easy if we can just kind of go about our day. But in our heart of hearts, that's not what we're there for, and we know that, and we're so good at helping families to bond with their baby. And I believe that's why our outcomes are so good because I think anybody who goes into neonatal care, whether it's neonatologists, lactation specialists, therapists, respiratory therapists, occupational speech, or physical therapists and nurses, we love what we do and we are amazing at it. I believe we're truly gifted at it and it's what we're supposed to do in life and what we were designed for. Okay, that was Liz in the white spaces there. And then finally, transitioning support across the continuum, a trajectory with very focal points along the way. We realize that it's very fluid and evolves over time. We don't have that partnership immediately. It happens over that course of weeks. And then we do have the education and we help them develop that skill and that guiding role over time. I love this. It talks about being honest about our desire for same assignment sometime. So nurse says, how come my assignment was switched? And the manager says, it's in the patient's best interest that we maintain continuity of care, so I should keep my old assignment. I don't remember you being upset last week when they gave me your assignment. That was completely different. That assignment was horrible. This one is easy. So again, sometimes we do just want to, we're having maybe our own personal crises in life, and sometimes we just need to know what we're going to count on when we go to work. So what are the challenges with continuity of care and maybe primary nurse role and primary nursing in your units? Again, it's blurred boundaries. Whose baby is it? It's the emotional burden that seldomly we realize we can have that risk of dependency. Think about it. 12 hours, day in and day out, week in and week out, month in and month out. There's a dependency on each other's part, and that is an emotional burden, and I don't think we realize that. Or maybe we feel it but don't acknowledge it and call it what it is. How do we maintain professionalism as well as balance between closeness and distance? Because remember, we have to let go. That happens when something goes wrong. If a child dies, we are traumatized also, and that takes a toll over time and over the years. This was interesting. One study actually showed a risk of longer length of stay and longer duration of mechanical ventilation. and wondering about, do we lose our objectivity? And that's something I think we need to think about. Do we feel maybe that baby needs 1 or 2 more days on CPAP or the vent? Are we sometimes, dare I say, too protective? What about feeding? Do we become experts in feeding? And we do feed. We feed day after day, 4 feedings a day, but we also have other teams who are experts. And do we make changes on our own style, based on our own style, or do we things in a team approach? And then do we risk longer length of stays because things that we might want to try? Just throwing it out there. What about poor or excellent continuity of one profession influencing the perceptions of continuity overall? We know it just takes one piece of bad information and it can totally upset the apple cart. The primary nurse, though, we can influence parents, independent or dependent. We talked about our attitudes, right? And help their ability to maintain or disengage relationships with other disciplines. If they hear us say something negative, because remember, we are their primary pivotal person. We're their family. They are dependent on us. So when we start engaging in a they versus us, they are going to hang on to that. And so we can help them engage with other disciplines or disengage with other disciplines. And there was this article called Hero Worship, where parents designated a single profession as distinct from all others. I will say that that is nursing, because we are with them most of the time. Parents also communicated to this hero before other professionals, and we've seen that happen on a daily basis. Parents may build trusting alliances with other disciplines, even if there's a flaw, but it's only if we support it, if we support those other disciplines. And then we, as a hero, whoever that hero is in that family's life, can help facilitate. If they are disenchanted, we can move them towards an alliance with that other discipline, benefiting everybody. So my question would be, in this one, a take-home is, am I able to communicate all views as accurate and helpful, or do I just communicate my view? Do I say statements like, I like to do it this way, or I like to use this? Or can we look at everybody's view and then be that one voice for that family, bringing all those views together and teaching that family how all different aspects can actually help. So finally, I want to talk a little bit about reframing primary nursing continuity of care, but looking at it as a process, not just as a step. We need this broad definition that involves persons and processes, and it's care of an individual, and here the patient and the family, the infant and the family, and it's care over time. So that means it has to be a process. It can't just be a person. So it's a process that optimizes parental access to information. It educates, it enhances competence of that parental role. It strives to make continuity very straightforward, manageable, feasible, and measurable. And that one article that talked about staffing helped to make it measurable. And it's a process with the working model that has key responsibilities and expected roles. It's not just I'm the primary nurse, and whenever I'm here, the family gets me, and I get the family. I think we need to have a take-home from this that says, in my unit, again, each unit has to develop this in their own way. Are we going to have primary nurse conferences? Are we going to have ongoing education for each other? Are we going to meet once a week when we have families that have a lot involved? What is that process? How is that going to look like? Do you have a process in place that if this family has primary nurses, education is being completed on an ongoing basis? What you would never want to have is a family that has 4 primary nurses, and then come the day of discharge, nothing is done. So you need to look at what is primary nursing going to look like as a process, and who will be involved in that process. Some more reframing is a process of adequate access to care, good skills, good information flow. is the care coordination between providers and organizations? Do we maintain consistency across those disciplines? What kind of information and knowledge do we provide? And is it pursued by all those involved with the family? It doesn't involve a person. It's all about this process. And is it a process where patients and families experience care over time? And is it coherent? Does it make sense to them? And then finally, well, let me back up. Process, it's not really about us. It's about the parents' needs. And then finally, it's a process that looks at passing the baton. How do we now provide continuity of care to our outpatient resources? They're going to be going to a pediatrician now. And if that baby is readmitted, they're going to be coming to our peds units. And assignments are very, very different. So how do we pass the baton? And I mean, how do we communicate to families what it will look like in the next stage, in the next phase of life? And here is another.
One of the nurses saying, well, can't you see that he's breathing? And I'm like, no, I can't see that he's breathing. It's like you can only focus on one thing at a time. And yeah, there's definitely an evolution there. And I do want to share about pediatrician that there is a harsh reality leaving NICU. So I like that phrase. You get such intensive, wonderful care, and especially being, long-time termers in there, everybody knows Fallon, everybody knows us. We get all this really specialized care and communication, and we can call, and you get to a point where it's like just so commonplace. And then you have to find your own pediatrician, and then you have to. You're a NICU parent, so you're worried, totally calm. You're like, what about this and what about this? And, am I going to already drive back to Dr. Easy with all of my calls?
You go from getting 100 questions a day answered immediately to
business hours only.
Calling out to NICU and asking the questions because that's where that transition. Yeah.
Okay. Back to me. Some comments and take home from that video was, I love when they said the harsh reality of living in a NICU. We get such intense, wonderful care, all this specialized care 24/7. And then when they leave, it says you're a NICU parent. You want to ask, what about this? What about this? And then dad just interjected so businesslike. You have 100 questions a day answered immediately. And you go from that to business hours only. And that transition is hard. And so I think we need to go beyond our process of continuity of care and then say, how do we continue and pass that baton to the next phase of that continuity? Because it does not end with us. And we know that. So how do we interact with our developmental assessment centers? Do we get feedback from them? Because they are seeing these families in these follow-up clinics, and how can we learn from each other? So I want to end with us have a review and having that spirit of inquiry that I talked about in the beginning, and asking ourselves this. What is my view of continuity of care, and how do I personally contribute to it in a positive or negative way? And again, I just want us to ask these things to us personally and kind of look in the mirror, because that's where professional growth comes from. Do I encourage attachment with parents and their infants? Do I help build NICU partnerships with parents in all of its phases, that acute phase, that stabilizing phase, and then that discharge phase? Do I promote my colleagues? Do I promote my physicians? Do I promote my lactation consultants? Do I promote my respiratory therapists? Do I promote my social workers? Do I promote my developmental team to enhance that consistency in communication and practice? What can I do? I love leaving any kind of program, education program that I go to, asking myself, what can I do the next time I care for a family based on what I've learned, but now based on what we understand families see as continuity of care. So what can you do? What can I do the next time we go to work? And then how can my unit build a primary nurse process? Or let's actually call it a continuity of care process that is purposeful, intentional, and meeting the needs of all involved. So how I challenge us to actually build continuity of care team. What would that look like? Is that weekly team meetings? Is that looking at everybody's role? Timeliness of getting primary nurses on board? But I want to emphasize that primary nurse role is pivotal, and it's pivotal though in providing that foundation of continuity of care, which is really what's most important to families. And on that, I will end and we'll discuss some questions.
Liz, thanks so much. That was a great presentation. Very, very thought-provoking. As Liz said, she's going to have a chance to answer as many questions as we can in the next 5 minutes. So, Liz, if you want to field a few right now, we'd love to hear your answers.
Sure. Okay, I've seen some questions come in here. One of the questions is, I'm working on a model of primary care nursing. I was wondering how we communicate with the parents about boundaries within social media with nurses and parents. For example, not becoming friends on Facebook, but asking them to visit to the NICU in the months and years to come. What a great question, especially in our social media frenzy right now. Actually, I do have some answers for this. A lot of hospitals now are actually putting guidelines in, but I'm going to separate this into two phases. The hospitals and health networks, which is HHN and the American Hospital Association, actually have looked at social media as a means of marketing, education, and providing health information. So your hospital probably has a Facebook page where they will share programs, education programs for families, or things that their local community hospital is doing or providing. So hospitals are using social media, again, for marketing, information, and education. Hospitals are also using, now again, I'm saying this from a hospital perspective, they use social media such as Yelp. Parents put evaluations on hospitals and their caregiving on Yelp right now, and might actually put it on Facebook too. So hospitals are looking at that, and I would encourage you to actually look at the hospitals and health networks and American Hospital Association for information. That said, they are also looking at our HIPAA, which is your Health Insurance Portability and Accountability Act, and they are starting to put employee guides in place to address the implications of sharing patient information, even if it's vague. For example, you might in your community, you might have had and I'm going to talk not necessarily about the NICU, I'll talk about maybe a PEDS or PICU unit. You might have had a community that had a tragic accident, and TV cameras are there, everybody knows what hospital those kids are at, and then all of a sudden a nurse puts on one of the worst days I've had in a long time. That's very vague, but that could be perceived as, did something happen to that patient? And so you're putting it out there. So that could be a HIPAA violation. So hospitals are trying to put guidelines in place for employees to actually protect employees, regardless of our intent. So you need to treat social media in the same manner as if you were on the phone or in person, because it is broad stretching. So social media policy needs to be in place, I think, for all hospitals to help mitigate the risk. Yes, use it to promote wellness, but you may want to eliminate it for employees just for your own protection. So I think that's helpful. Also, the American Nurses Association provides guidelines on social media and networking, social media and networking for nurses. They have a National Council of State Boards of Nursing, and the ANA have actually mutually endorsed each other's organization's guidelines for upholding professional boundaries in a social network environment. So again, I encourage you to go onto the internet and look at hospitals and health networks, the American Hospital Association, they are addressing it, and then also go on the ANA, American Nurses Association, and then the National Council of State Boards of Nursing. So I would encourage that. Another question says here, let's see, has anyone expanded this primary model to include neonatologists? That's another great question, especially if we put more emphasis on continuity of care. So can we have a primary model that does not include the primary nurse? Yes, I think what you have to do is focus on providing continuity of care, which is why we want to say it's a process and not just a person. So maybe we need to start talking about providing continuity of care teams where everyone speaks the same message and we all understand what our roles are going to be. And so maybe that means our continuity of care team includes a neonatologist, which means once a week there is a family conference that they maybe initially initiate. And that might be one of their roles, or every day or every other day they will meet with this family, or meet once a week we meet with the team, and not necessarily as rounds, because maybe certain families and their situations need a little bit more focus and time together because of social situations or the acuity of that patient. And it's not just the nurses meeting or just the therapist meeting, but all of us meeting as a team. So I highly encourage a continuity of care model that would include every single discipline. Another question here, a final question that I see here says, I work in a 125-bed unit and our charge nurses tell the parents when they ask about primary nursing that they are unable to meet this request due to scheduling conflicts. Any thoughts? Yeah, a little bit of a tough one, because every unit has, or many units are going to staffing acuity tools. And each unit, each state has their own staffing ratios. In California here, we're very, very lucky. And we have very limited, very tight staffing structures. But that said, there is evidence that we've talked about that primary nursing model does decrease the utilization of resources and improve outcomes. So based on that, I would think leadership maybe can look at some of the evidence and see how maybe you can take a small portion. I don't know if you're single beds, if you have pods, but it might be fun to take a pod or a small area of your 125-bed NICU and get a team together and see how you can make it work, kind of do a test of change, and then bring it to your leadership, because that's their responsibility to make sure that staff are safe and that they are following their acuity models. But it doesn't mean that you can't move to looking at it. And so I would encourage you to maybe do a quality improvement project. I'm not sure what the conflicts are, because I don't know what state you're in, and I don't know, I'm sure your managers have reasons for that. But again, I would emphasize the decreased utilization of resources, try to get that article, suggest maybe teams and do a small test for change and do a little project. And I think that's probably it.
Liz, thanks again so much for a great presentation. Again, this webinar was brought to you by DandleLION Medical, and we are really thrilled to have experts like Liz who are willing to share their information with you and with the 10,000 other people that are on our webinar mailing list. I want to let you know, too, that DandleLION has just brought out 3 more organic skincare products. In a recent survey done by families, the majority of moms was very concerned and very interested in using and buying all natural and organic products for their babies, and 82% of those moms were really felt that they needed help and guidance in this area. The 3 new products that we're just bringing out are Skin to Skin Massage Oil, Nurturing Balm, which is an organic diaper rash cream, and also Soothing Cream, which is great for moms and babies, and it helps not only to moisturize skin, but also helps to soothe rashes, eczema, or any other bothered skin. There's a place in the evaluation form to note if you're interested in receiving some free samples of these products, along with more information about the importance of why organic skincare products are so terrific for kids and all of us. Moving on to the continuing education credit, in order for you to receive your free CE, you will need to fill out the webinar evaluation. The link to that evaluation is on the email that you received, as well as a link to this recording and a PDF of the slides. Remember, if you're viewing as a group, you must each log into the evaluation form in order to get the CE. Please visit the Dandelion Medical website for future webinars and also links to the recordings of our previous 22 webinars. They're all still active and available for continuing education credit. So again, thanks for listening. Have a great weekend. We really appreciate your participation. And thanks again to Liz Drake for another great Dandelion webinar. Have a wonderful day.